I'm Drs Shore. I'm the medical director of Carolina Urologic Research Center in South Carolina in the US. I'm a urologic oncologist. Today's program is brought to you by eCancer, and we're really happy to review the most recent cutting edge presentations from ESMO 2020. It was a virtual program this year, but nonetheless, there was some really great activity. And what we're going to focus on today is the topic that's really very important right now, known as homologous recombination repair defects, gene alterations. How do we find these patients? How do we appropriately test for them? And more importantly, what are the data that are coming forward and have been presented most recently here at ESMO 2020? We're going to review the phase 3 trial known as the PROfound trial, which has had a New England Journal publication, as well as a presentation on its benefit for patients who have HRR mutations. We're also going to review different presentations, abstracts from ESMO 2020, which included topics on testing in North America, testing within Europe. We'll also look at some other early phase trials combining different PARP inhibitors with other well-known CRPC therapeutics. And of course, we'll have an interactive discussion with our faculty. I'll just begin by commenting on this notion of HRR mutations, or what some might call DNA repair mechanism defect alterations. We're familiar with the notions that they can be within the germline, where you would have inherited these from your mother and father, and therefore, if they are inherited, they essentially have ubiquity in all the cells of your body. They can be both monoallelic and biallelic, and we'll talk a little bit more about that. And then you can inherit, or not necessarily inherit, but you can develop alterations in these HRR mutations, homologous recombinant repair mutations, from the tumor tissue itself. And we call these somatic alterations. We can test for them both with tissue as well as with liquid-based testing. And we have, renowned experts on this call today. Both, Kim Chi and Elena Castro have done really super pioneering work in understanding the incidence, prevalence of these alterations, both in patients who are newly diagnosed with high-risk disease, who have family histories, patients who have metastatic disease, both castration-sensitive and castration-resistant. So it's not a question any longer about when do you need to be thinking about this testing, or when you need to be thinking about these therapeutics, these PARP inhibitors, which we're going to describe. It's the essential comment is you have to be doing this now, because this will help optimize your patient care. So let's begin with you, please, Niraj. Can you comment on the presentations that we had at ESMO of the PROfound trial, a global trial that, as we all know, will clearly change the landscape of therapeutic options for mCRPC patients?
Absolutely. Thank you so much, Neil. It's such a pleasure to be here on the panel with you, world-renowned experts like Dr. Chi and Dr. Elena Castro. So thank you for the opportunity. I think, no doubt in my mind, one of the most exciting presentations in ESMO 2020 scientific program meeting was the PROfound trial, as presented by Dr. Joaquin Matteo. I would just go with the introduction of the PROfound trial first, followed by the results. PROfound trial is important to me because this is the first ever conducted successful positive phase 3 trial in patients with metastatic castration-resistant prostate cancer, where patients were selected based on a biomarker. This was a history in making in prostate cancer. Until then, prostate cancer never had a single trial of this magnitude where patients were selected based on biomarker. So out of 4,500 patients screened originally, or who were actually pre-screened or screened for patients for this trial, ultimately 400 patients were registered approximately 400 patients were registered. There were two cohorts, Cohort A and Cohort B. Cohort A included 245 patients who had BRCA1, BRCA2, and ATM mutations. Cohort B had 12 other mutations, which are non-BRCA1, BRCA2, or ATM mutations, 145 patients in Cohort B. And the primary endpoint was radiographic progression-free survival in Cohort A. And then, of course, there were several secondary endpoints, such as radiographic progression-free survival in all patients, and like time, how much delay was there to time to pain progression or time to cytotoxic chemotherapy and so on. So I'll focus on the primary endpoint data, which were, and the overall survival data, which were presented in ESMO just last week. Previously, we have seen the data on radiographic progression-free survival being presented in ASCO meeting. So regarding the overall survival data, what we saw in this meeting, these were the final overall survival results from the PROfound trial. We saw something really striking. In these patients who had progressive metastatic castration-resistant prostate cancer, progressing on a novel hormonal therapy with abiraterone or enzalutamide, and many had disease progression even on chemotherapy with docetaxel, when they were randomized to a PARP inhibitor, olaparib, versus a alternate NHT with either abiraterone or enzalutamide, there was a very remarkable, significant overall survival benefit with a hazard ratio of 0.69 favoring olaparib. The median overall survival was almost 4.5 months, improved from approximately 14.5 months in the control arm to 19 plus months in the experimental arm with olaparib. And I would like to bring this to your attention that 66% patients in the trial had crossed over during the conduct of the trial from the control arm to the experiment arm with olaparib. And we all know that whenever we see this crossover, the crossover has the potential to attenuate the degree of survival benefit. So what I think was quite interesting is that the effect of crossover was adjusted by mathematical statistical formulas. And then what we saw was, if you adjust for the crossover of those 66% patients from novel hormonal therapy to the olaparib arm, the overall survival improves even further, bringing down the hazard ratio to 0.42 favoring olaparib. And I think this is a very exciting news for our patients.
So thanks, Niraj. That's a great overview. And so, yeah, so not only was the primary endpoint met for the rPFS, but now the secondary endpoint of overall survival was demonstrated. And that's what Joaquin did such a great job of demonstrating. And to your point, not only was it met, but there was a really high crossover, which, and anytime you do a crossover, it sort of blunts the delta, so to speak, of those patients who would have never received an active therapy such as olaparib. I think it's also interesting, as you say, it kind of puts another nail in the coffin, at least the way I think about it, in sequencing the androgen receptor axis drugs, especially when you can personalize, as you say. This is a landmark trial, is that you now have compendium testing to say, I have an HRR mutation positive finding, and here I can benefit clearly from a unique mechanism of action, a PARP inhibitor, as opposed to sequencing to yet another well-known androgen receptor axis drug, whether it's abiraterone or enzalutamide. Kim, what do you think about this? I know you're a co-author here. You've been very involved. How will this change how you manage patients, or how our colleagues should think about managing patients going forward, assuming they have accessibility?
So I'd like to touch on 2 points. One is your point about next generation hormone therapy. And as we can see, again, multiple studies have shown that switching from one next generation hormone therapy to another really yields minimal benefit. And in this case, patients were progressing within 3 months. And really that's from one scan to the next. So it is not benefiting our patients. I think the other point to emphasize is this degree of crossover. And we have to remember that on average, on the control arm, patients were progressing at about 3 months and therefore crossing over. And yet we still saw this huge survival benefit. So emphasizing that earlier treatment is better. And we've seen that over and over again in multiple trials that we've done in prostate cancer. Earlier treatment is better. So we really need to identify these patients and get them the treatment earlier so that they can have the most benefit. Delaying with another next generation hormone therapy, and we could argue about chemotherapy as well, may not be in the best interest of these patients.
Elena, your thoughts on this study?
Yes, I agree what is being said previously, that this is a shift in the management of prostate cancer entirely, and that we should start screening for these alterations as soon as the patients become at least metastatic, in order to start having a whole picture of could be the best treatment for our patients. So we can consider a PARP inhibitor, if that is the case, as soon as possible. Because what we have seen is that at least for some of these alterations, patients have very poor prognosis. It may not be applicable for all the HRR alterations, but at least for some of them. And there is really a chance to change the prognosis of these patients by using a PARP inhibitor as soon as possible. So definitely, I would recommend to do this and try to screen all patients and as soon as possible.
So let me ask you all a question about, Cohort A was BRCA2, 1, and ATM. And we see the most common of these, the 15 gene panel was BRCA2. Not surprising, we've seen that in other PARP inhibitor trials where testing has been rigorously performed. You'll hear some of our colleagues say, well, most of the RPFS and the OS was really dominated by the presence of the BRCA2. I'm curious now if you had access to olaparib based upon this data, and in the US, the FDA has now approved 14 of the 15 genes that were studied. And based upon the trial design, so if a patient's MCRPC and they're progressing after a novel hormonal agent, typically ABI or ENZA, they don't have to have received docetaxel, or they can. And you check the patient with germline or somatic, or maybe both, and they had one of these lesser of the 14 genes, and that was in cohort B. How do you think about advising patients, Kim, and then maybe Niraj, and then Elena?
I think that's a great question, Neil, and it's on the minds of many of us about how are we going to prioritize these biomarkers for selecting patients for treatment. And I think no doubt BRCA2 demonstrates a very high response and a large benefit for patients. But when we look at some of the subgroup analysis, some of those other genes, we don't see as good of a benefit in the population. However, we know from some single patient, single gene analysis that there are gene alterations that respond well to PARP inhibitors. But the numbers are so small because you have this long tail on the curve of these other alterations. So for example, RAD51, PALB2, I think these have been associated with high response rates, although the numbers are very small. So at this time, I think it's difficult to answer that question. I think I'd be less enthusiastic about ATM and CDK12 if I have an alternate treatment to try. So we know that we have docetaxel, cabazitaxel, for instance, and most studies have demonstrated good activity of these agents in patients with homologous recombination repair defects. So I think if I have an alternate treatment to try with known efficacy, I would probably do that prior in these particular alterations. But however, if there was another patient with PALB2 or RAD51, I'd be more inclined to try the BRCA2. There's not enough data. So what we need to do is continue our studies in this, analyzing not just the alterations, but other ways of identifying patients with homologous recombination repair defects.
Great, great. Niraj?
Yeah, I agree with what Kim said, most of it. I always agree with him anyway. But But I agree. I'm like, ATM is somewhere where I'm not feeling comfortable. I think we need more data on ATM. But otherwise, I would like to point out that individual number of patients with individual gene, how many patients were there in each one of those small cohorts of those 12 genes. They're so small that it is difficult for us to infer the advantages for each of those groups. So I think I won't get into subset analysis beyond ATM. ATM was a pre-specified analysis, so I think I'll stick to that. But other gene analysis, when I see my patients with PALB2 mutation or RAD15 mutation, I tell them, look, this is a trial which included these patients, and you got to try this. And what else? What are the options we have? Most of my patients, I'll be honest with you, most of my patients are not interested in chemotherapy with docetaxel and cabazitaxel. And alternate NHT, Kim study have shown us that alternate NHT doesn't work very well. So what are the options we have? So I think if I have a phase 3 trial showing benefit with olaparib in these patients, I would try that.
Just for time, let's switch over to some of the other work that we saw at ESMO, and I'd like to get your thoughts first on this, Elena. Let me kind of review some of the things that I was fortunate enough to be part of. We did some retrospective analysis of a large data registry known as the Flatiron data registry in the US, a little over 5,000 patients over a 6-year period. Medical oncology practices, 90% community, 10% academic. And what we found during that 6-year period from 2013 to 19 was about 13% of patients were receiving testing for HRR mutations. The majority of it was germline, and a very smaller minority was somatic testing. Now, you can argue that, well, why would I be testing, doctor? Because if I'm in one of those clinics, but if I didn't have a clinical trial, which of course we always think that's a great thing to be doing. We should be enrolling patients in clinical trials whenever possible. All the international guidelines support that. But if I wasn't part of a clinical trials access and I didn't have an approved therapy, so why would I test? Well, the answer is now because you have an approved indication and actionable findings. But in our study, it was only about 13% of these patients were receiving any type of testing. And then in a second abstract that we presented of that same registry, we looked at sequencing regimens, and the patients who had the testing and were HRR mutational positive did particularly poor. The other finding in that other second abstract we presented at ESMO was that no surprise, but the algorithms, the recipes, the cocktails for how our colleagues across the US, and I think true for the world, are sequencing our patients, it's kind of all over the place. And so now that we have the opportunity to test someone and quote, personalize their care, could theoretically really optimize their delay in progression and their survival. And similarly, there was a nice presentation of the largest 5 European Union countries by Leith and others, which also showed a remarkable paucity of testing. So Elena, what do we recommend now to our medical oncology, our urologic oncology, radiation oncology colleagues, not just really in the EU, but in North America and really globally about testing? Your thoughts on getting maybe a little more granular about germline and somatic testing?
I think this is going to change, as you were saying, now that we have some therapies that we can use when we identify any of these HRR alterations. So for sure, I'm convinced that the uptake of tumor testing will be increased. With regards to germline testing, I believe most clinics, more hospitals have access to genetic counselors and genetic testing, but it has not been until recently that the guidelines have been updated to include the recommendation for germline testing for patients with metastatic prostate cancer. So in many countries, if this was not included in guidelines, there's no chance of reimbursement. And in most health systems in Europe, this is one of the things that drives the opportunity of having the therapies or counseling reimbursed that will drive these decisions. The other thing is there is a shortage of counselors in order to provide counseling and testing for all the patients with prostate cancer, ovarian cancer, pancreatic cancer. So this is something we will really need to improve, either by acquiring ourselves the needed skills to provide a minimum counseling to our patients in order to recommend this testing. Pre-counseling should always be done before requesting the test, but it could be a very short test without the need to refer to a counselor. And then when the results come back, if needed, if it's a positive test, then refer the patient to the counselor. But germline testing, I believe, is something we should be doing for all our patients with advanced disease, because around 10% of them may harbor a germline mutation. For patients with BRCA2 mutations, it is clear that will have an impact on their prognosis. Of course, we have all these PARP inhibitors, but also we don't really know which is the best treatment sequence for these patients. I'm sure that we will have more studies in the years to come, and we will better understand what is the most appropriate sequencing for these patients. But we have to do that for their families, for their healthy relatives at risk of increased different types of cancer.
Yeah, I really appreciate your commenting that we have to up our game. It's great if you have a genetic counselor, certified genetic counselor who has oncologic training and is not just schooled in reproductive genetic counseling, and that's ideal. But I think practically speaking, for the world, we need to up our game and be able to have some understanding of what is a positive HRR mutation mean, and other mutations as well, both germline and somatic. Let me ask you, Kim, if a patient is being seen by his or her medical oncologist, and the patient has MCRPC, they're on Enza or Abi, and they get a germline test and the germline's negative. Is that it? Do you just stop there? What do you do next, or anything?
Well, we know that for patients with metastatic CRPC and have a homologous recombination repair defect, about half of them are germline, roughly, as Elena said, about 10%, but the other half are somatic. And so that's an important factor. So you're only picking up half or even less of the patients that could be eligible for a PARP inhibitor, as well as understanding their prognosis more. So I would also advocate that all patients get tested, not only just for the germline, but also the somatic as well. And there's various ways of testing this. And I found your abstracts very interesting, Neil, because of the low testing rate, and it's widely accessible in those centers as well. So only 10% of patients, or roughly 10%, were getting tested. And even just on the germline alone, it really should be closer to 100% of people getting tested because of the implications for families. But we also have to emphasize that we need to do the somatic testing as well.
Yeah, no, thank you. This is a sea change. I mean, this is a big deal. And, we have a lot of data over the course of our congresses that we make some incremental, advances. This is a big incremental advance. I mean, this is a real change.
And it's a huge number of patients as well. Like, this is prostate cancer, not, ovarian cancer, which is a relatively small numbers. And so we need to work with our hereditary cancer folks and genetic counselors to get this organized. Our team is starting large class pre-test counseling, as well as video counseling, so patients can do it from the comforts of their home. So we really need to change how we do things at this point in time.
Yes, sorry, I was going to say that I totally agree. This cannot be excuse that we don't have, we have so many resources to counsel these patients, to explain them why are we doing that, and we should use them. But definitely we should do testing in all our patients. And I didn't mean only germline, definitely both germline and somatic, but there's so many ways how we can counsel our patients. That shouldn't be the reason why not to do it.
Yeah. So Niraj, what are your thoughts about the differentials between tissue testing, somatic versus liquid testing? Sometimes that creates some confusion, I think, for our colleagues who are sort of getting into it. If you're going to tissue test it, when do you get the tissue to test it? Is it the primary organ, the prostate? Do you get it when they're castration sensitive, metastatic? Do you wait for them to be castration resistant? Where are you right now and your thoughts on liquid-based testing? Are they the same? Do you get the same concordance of positivity?
Those are great questions, Neil. First of all, I agree with Elena that these are early events. At least that's what I have seen in my clinic. So anytime I see a patient for the first time with advanced prostate cancer, and this is my practice, which I have been following for at least last 1 year. Anytime I see a patient with advanced prostate cancer for the first time, when I am ordering CT scans and bone scans and hemoglobin levels, I order 3 more tests at the same time: tissue comprehensive genomic profiling, liquid biopsy, liquid CGP profiling, and referring the patient to Germline clinic, high-risk genetics clinic. This has become the part of my initial workup for all patients with prostate cancer. I know that many of the patients would have had a prostatectomy 5-7 years ago, and the tissue may not be eligible for testing by CGP. Most of the commercial testing platforms don't want to accept tissue which is more than 6 years old. Regarding liquid biopsy, we are going to present in the GeoASCO the concordance of hundreds of solid tumor biopsy versus liquid biopsy. And I can tell you right now that concordance for the overlapping genes is pretty good. The liquid biopsy platforms, it has been fascinating to see liquid biopsy platforms evolving so well and so nicely that they are now competing with solid tumor panels, at least the commercially available ones, which are easily available. So that's my take. Every patient should be tested whenever we see them for the first time, not necessarily waiting for onset of mCRPC, because sometimes we lose these patients if we wait for an onset of more aggressive disease, or we lose the tissue, or tissue is thrown away by some of the local hospitals. So I think test these patients early on as much as possible.
Yeah, no, thank you. I agree. I mean, I do exactly what you do. I do exactly that. And I've been doing it for a couple of years. And it's really, you sort of have like a eureka moment. You go, wow, I found something now that is actionable. I can put you into a trial, or now we have approved therapies. So I completely agree. And you're right. I mean, sometimes, the biopsy specimen, the archival tissue, the prostatectomy specimen, you can't get access to it. It may have been poorly preserved. It may have degraded the tumor tissue. So I tend to have the mindset of, seize the moment while I can. Of course, for all of us and everyone listening around the world, accessibility to doing this and costs are clearly considerations. And we need to continue to fight for our patients to be able to have that. So with the time remaining, there were some really interesting abstracts of combination concepts. And so now that the PARP inhibitors as a class are here, and there are, olaparib is really the first in class to have a phase 3 trial in the US. We also have rucaparib, which has received FDA approval. There are 2 other PARP inhibitors that are being actively trialed across the world, niraparib and talazoparib. There are combination studies combining the PARP inhibitor drugs with checkpoint inhibitors. There's a nice abstract presented with a combination of pembrolizumab, part of the Keynote 365 large phase 2s. There are combinations with previously and ongoing with abiraterone, with enzalutamide. And so there are combination work being done. The NRG had a nice paper looking with ADT and radiation therapy patients who had HRR mutations. What are some of your thoughts? Let's maybe go around the room with Niraj and then Kim and Elena. Where you think the future will be going. We typically in prostate cancer, right? We always, get approvals with the patients we look at and who we accrue are the most advanced, heavily beaten up, as the PROfound trial showed. These were patients with extensive amount of tumor burden, multiple lines of therapy, and yet got a great result relative to, the terminal nature of their disease. So, where are you optimistic, Niraj? You do a tremendous amount of trials.
I remain very optimistic about use of PARP inhibitors in patients who are selected for DNA repair gene mutations or defects, either in germline or in somatic or in tumor tissue. However, I do not feel as enthusiastic for use of PARP inhibitors in unselected patients. So far, we have a small phase 2 trial which have shown some encouraging signals, but if you look at the pembrolizumab olaparib trial, the Key Link 010 trial, the disease control rate, if you look at the objective response rates in unselected patients, it's still around in single digit or around 10%. The original trial by Dr. Karzai, Fatima Karzai from NCI, and durvalumab with olaparib, I think it was olaparib, the PARP inhibitor, most of the patients who responded were selected for DNA repair gene mutations. But we'll have the answer very soon. I think that 3 large phase 3 trials are going on. All of us are on the panels and steering committees of those trials. And those large trials are recruiting patients with androgen deprivation therapy plus novel hormonal therapy plus minus PARP inhibitors such as talazoparib, olaparib, and niraparib. And I think it's a matter of time in next months or years, next 1 year, we'll be starting to hear how these agents performed in unselected patients. So I will cautiously waiting and watching.
Yeah, absolutely. Kim?
So I agree with Niraj, and we often agree together with these things, as Niraj stated earlier. But I think we'll see, we've seen great benefit in this late stage biomarker positive homologous recombination repair altered patients, and we'll see that move earlier into the disease, into castration sensitive disease, and then into even localized disease. So I think that's a reasonable way to proceed, and I think we'll see benefits there. I think for unselected patients, the jury's out. There's a lot of hypothesis for the combinations. However, I think we'll have to remain to see whether it pans out in phase 3 trials.
Yeah, and Elena, maybe I'm sure you probably also agree, but I want to hear your thoughts on combinations that you're working on, and maybe if you would just comment for our colleagues listening about any particular adverse event management that's sort of as a class that one could expect to see with PARP inhibitors.
Well, with the combination of PARP inhibitors, for instance, with abiraterone, we have seen a number of patients with hypertension, with manageable, but significant number of patients develop hypertension. And there's also with an increased creatinine, which has been is not related to renal failure, but is rather associated with the renal transporter. So it's quite common to see in patients treated with PARP inhibitors rise in creatinine. That doesn't really mean that the renal function is being altered. And of course, the anemia. Anemia is probably the most common side effect. Thrombopenia in some patients, nausea more than vomiting, and in some cases asthenia. But I have to say that in general, in my experience, PARP inhibitors are quite well tolerated. And once again, patients who receive PARP inhibitors earlier usually have less toxicities and can benefit from these therapies for longer. So once again, we should try to use them as soon as possible in those patients likely to benefit from them.
Oh, great. Thank you. That's been my experience as well. Well, I think we've had a great discussion. I'd like to give y'all just 30 seconds or so as sort of a wrap up, take home message for our colleagues as it relates to this, PARP inhibitors, germline somatic testing, and some of the pearls that we learned from ESMO 2020. Let's start with you, Niraj.
We have, for the first time in history of prostate cancer medicine, a very well-tolerated class of drugs known as PARP inhibitors in the form of olaparib and rucaparib available in the clinic for those patients who have germline mutations or somatic mutations in the DNA repair genes. These agents improve survival, improve response rates, delay chemotherapy drugs. There is no reason for us not to test our patients for these mutations anymore. Every single patient with advanced prostate cancer should be tested for gene mutations in DNA repair genes.
Oh, great. Well said. That's hard to follow that one, Kim.
Test early, test everyone, and we should be using PARP inhibitors in those that are homologous recombination repair altered.
Yeah, great. And Elena?
I will add something else, that with the results of the hypertension trial that was also presented, we will be testing early, and not only for HRR defects, but we will start testing for a number of other profiling tumors, for a number of alterations that are finally targets for available therapy. So it's an exciting new time, and we should really, really get ready for it.
Yeah, you're spot on. I love that you brought that up. We need another hour to talk more about some of these other important studies. The IPAT trial is a great trial in the whole notion of these, PTEN loss alterations and treating patients in this other remarkably new class of PIK3 AKT pathway drug targets, epotasserib, capivatasserib. Really exciting, but you will never know to do it if you don't do the testing. So thank you for that last comment, Elena. That's great. And thank you all for your dedication and all the work that you're doing. Thanks for your impression of some of the work that was presented at ESMO 2020. And we thank the folks at eCancer for allowing us to speak with our colleagues throughout the world, and wish everybody well and safety and health and happiness during the pandemic. Thanks very much.